Live now. You may see it before I do.
Okay, I think it is live. So good evening, everyone, and welcome to the Health and Wellbeing Board. I'm Councillor Josh Blacker, Cabinet Member for Healthy Lives. I'm technically not the chair of the meeting yet, but Peter has asked me to chair this meeting and will be updating the Council's standing orders to reflect that. Peter, did you want to say a word now just about that and why you think that's the right way to do this meeting?
Thanks, Councillor Blacker. We are in a situation where sort of the peculiarities of the Council's constitution set out that I technically am the chair of the Health and Wellbeing Board until we change the constitution. One of the things that I've done as the new leader is to set out, actually by splitting the role of public health improvement and public health protection between two cabinet members. One, well, partly reflecting the sort of the scale of the challenge of COVID and the degree of sort of focus that we need to give to a series of priorities. And so the cabinet member for Healthy Lives has responsibility for adult social care and health protection. And the cabinet member, Councillor Dr. Aisha Raza, for tackling inequality, has responsibility for public health improvement. So sort of in order to make sure that we are reflecting those new priorities, I'm sort of vacating the chair to sort of make sure that it's cabinet who are in the lead on particular areas of their portfolio. That doesn't in any way undermine or diminish the extent of the priority that we give to this meeting and to the partnerships that we build both with our public health and with our NHS colleagues and also with community organisations. Merely a fact that it's appropriate that the cabinet members who are leading those portfolios and leading those agendas are the ones that sort of chair this meeting too. I will continue to remain a member, and I know that there are colleagues on this call who I've gotten to know over the course of responding to COVID, but equally will recall my time as the chair of the Health Standing Scrutiny Panel and took a very, very active interest in the public health outcomes framework as it was then, and the sort of shift of public health responsibilities into local government. And it's an area that I sort of really continue to remain passionately interested in. I just will not be chairing. Perhaps what it will do is maybe allow me to say more than necessarily brokering what who gets to say things. So that's sort of the rationale for why we're doing it. We have not yet changed the Council's constitution. We need to do that formally. But if members are agreeable, I will sort of, if you like, hand over the chair to Josh to continue the meeting.
I don't think anyone disagrees, which is fantastic for me. Gives you one less thing to do. So thank you, Peter, and thank you to everyone for indulging us before we've changed the constitution. Keith, have we had apologies from anyone that we need to note?
No, but I think Anna may be coming in slightly later, as you know, I believe.
Yeah, so Anna Bryden, Director of Public Health, is running slightly behind this evening. So we'll skip past the items 8 and 9 while we wait for her. And we'll come back to them as soon as we finish the item that we're on when she appears, if that makes sense. Keith, if we could let Simon in, that would be great. I'm aware that I recognise a lot of names. I know I've met with a lot of colleagues already, particularly on vaccine calls. So, you know, Neha and Vijay, I know you, but there are names I don't recognise. So apologize if when we do speak, rather than do a round of introductions now and take forever, as and when people do speak, I will ask you to introduce yourselves when you speak for the first time, because I think that's probably a better way to manage it than try and remember which of you I've asked to introduce yourselves and not on a two pages of Zoom. So we'll move on. I don't have any urgent matters. Does anyone have any declarations of interest they need to make? No, excellent. I don't have any matters to be considered in private. And I'm going to ask those who were members at the March meeting whether the minutes of the March meeting are a correct record.
Yes, I think we can confirm they're a correct record. Thank you.
Fantastic. Thank you, Judith. Which brings us on to item 7, the Health Watch Vaccine Attitudes and Experiences report. Matthew, are you able to share your, was it a presentation? It was just the report, wasn't it? Sorry, not a presentation.
So I'm just going to update you verbally, if that's okay. I don't.
That's absolutely fine.
Presentation. So just to introduce.
And sorry, Matthew, if you could just introduce yourself. Sorry. Oh, that's what you're doing. Sorry.
No problem. So my name's Matt Dunmole. I'm the Ops Manager for Health Watch Ealing. And it's lovely to meet you all who I haven't met before. So the main purpose of the Health Watch update today is to provide a brief summary of the COVID vaccinations, attitudes and experiences of our vaccinations. And then I was just going to provide a brief update on other areas of Health Watch work at the moment. So to jump into the vaccination report, as some of you may or may not remember, we were conducting a series of Tri-Borough Webinars with Health Watch Hounslow and Health Watch Hammersmith and Fulham from December to March of this year. These webinars were kind of designed for a public-facing role to provide as much information as possible, while also bringing in professionals to provide any updates to services that would be beneficial to members of the public. And as things kind of evolved, we recognized that it was a good opportunity to understand people's attitudes and experiences towards and of the vaccination. So this report kind of shows that evolution. And so while things are fairly preliminary at the start, we kind of get into more detail as we come towards March. So in the initial webinars, people shared a number of concerns, including concerns around adverse reactions to the vaccination, unrepresentative demographics for the trials for the vaccination, and question marks over the trial time period. These led on to questions about how COVID-19 can mutate and whether this would bring us back to square one in terms of the vaccination rollout. And also some questions around what the NHS was doing to address specific concerns that had come up due to adverse reactions of people receiving the vaccination. So these findings kind of went on to shape our subsequent webinars and kind of dictated who we wanted to bring in. People very kindly provided presentations on specific services, and public health partners came in to kind of address any myths or misinformation that was going on to provide the public with some peace of mind. Moving on to the February webinar, we used a list of poll questions to just determine the attitudes towards the vaccinations. Out of all the attendees, 80% of attendees indicated that they would take the vaccination. Some attendees mentioned that logistical factors may prevent them from taking the vaccination, and this included things like distance to a vaccination center, public transport links, and the availability of appointments, which we kind of then recognized as we moved into March that there was a targeted approach by health partners to alleviate these issues. So it was good to see that those concerns were being addressed straight away. Then following that, in the March webinar, although attendance was smaller, the majority of attendees had been vaccinated. In addition to some attendees referencing the impact that the pandemic had on accessing non-related COVID health services. So despite some people being vaccinated, there were still concerns that they couldn't reach health services that were providing non-COVID related care. Dr. Mahmood's presentation from Hounslow found that 75% would take the vaccine, alongside some interesting findings on the ethnicity breakdown of vaccine hesitancy. And these are actually shown to members of the public to understand in more detail what we could do to alleviate these concerns that people were feeling. And we came up with several recommendations that are outlined in the report, including peer-to-peer education, mobile vaccination sites, and targeted approaches to specific, using specific religious or community group connections to support both of these. From the interviews that we conducted to supplement the webinars, we found that 94% of people had had a positive experience at a vaccination centre. And this totaled at 44 people from Ealing, with the remainder coming from other boroughs. So feedback indicated that the vaccination sites were well organised, very efficient, with very polite and friendly members of staff. And the kind of evolution was evident through this kind of key finding that at the first webinar, 58% of people indicated that they would take the vaccine. By February, this had increased to 80%. So a lot of the work that all the health partners were doing within the borough clearly made a significant difference. By March, 28.5 million people had been vaccinated, and this was reflected in our findings as well, as 88% said they would take it once it was offered to them, with 73% already having the vaccination. And it was noted by two guest speakers in the March webinar that Black Caribbean and Black African communities and areas of deprivation had a low vaccine uptake, and therefore our kind of targeted approach should start to work towards these areas of deprivation in order to understand how we can further support the vaccination rollout. Finally, it must be said that attendance was stronger from Hounslow residents for each of the webinars than Ealing or Hammersmith and Fulham, so we do have to kind of take this into account when we're looking at the findings. However, we did attempt to rectify this through a big interview push in Ealing, and this was kind of reflected in the findings that were overwhelmingly positive for the vaccination rollout. So I'll just stop there, because that's my summary of the vaccination report. So if there's any questions, I'm happy to take them, and if not, I can move on to the other updates.
Brilliant, thanks, Matt. It's a really timely report, and we're given the push that we've been doing recently anyway on vaccinations, so it's really helpful. Are there any questions for Matt then? I don't know, we will come back to the subject of vaccinations later under the COVID update. So if we, and I know Anna may have some things to say as well, but we do have Neha and others from the CCG who I've been on many calls with about vaccinations. So I don't know, Neha, if you wanted to say anything about vaccinations, but I think the point about, you know, certainly thanking all the staff who are delivering them is a very good one. I mean, I walked into CP House and had mine kind of, you know, as quickly as possible. It was a fantastic service. So Neha.
Yeah, I'm so pleased that you've got a positive response about the experience of patients at the vaccination centres. We've put a lot of work into the vaccination centres, and everyone has felt privileged to be a part of it, and there's still so much more to do. So it's really gratifying to know that the staff and their approach to trying to get us out of this pandemic has been recognised, and it was a positive experience. We've brought reports here previously about vaccination uptake and where we've got to really target our communications and in trying to get certain population groups vaccinated, and it's really timely, as you said, to receive this report actually today. So really pleased, and if there is any more feedback that you receive through your normal channels, or if you do any further work and there is any updates, please keep us updated as you go so that we can tweak or change as needed through this programme.
Absolutely, yeah. Thank you, Neha.
Right. Councillor Raza.
Hi, Matt. Thanks for that. That was really good.
No, Aisha, you'd like to
my
introduce your
question
cabinet
or
role.
my comment really is, what do you feel? Oh, sorry. I'm the cabinet member for tackling inequalities, and that includes the public health part of health. So that's why I'm on this board. But going back to what you were saying about there being not as much uptake in Ealing, Is there anything, Matt, that you think that would be better, or how could we get that uptake to be better in Ealing? And did you think there was any particular reason why we weren't as good as Hounslow on that? Because that is slightly worrying that people weren't engaging with what seems to be a really excellent piece of work and really could have done with our input.
Yeah, I think there are a couple of issues in terms of uptake for these webinars. Internally, we were going through a change of staff. Our engagement officer left kind of halfway through the webinar series, and we kind of worked to get somebody new on board, but they didn't come in time. So a lot of the work kind of fell on the shoulders of people who had other focuses as well. And then we're doing a lot of work at Healthwatch Ealing to try and strengthen our community relationships, because I think I've mentioned before, actually, they were quite fragmented prior to the pandemic already, due to a couple of changing of hands at Healthwatch. So nobody really got the chance to sink their teeth into it. And then obviously the pandemic came and everything went virtual. So it was really difficult to form those relationships, I guess. So it's definitely still a work in progress. And we hope that as we move towards face-to-face community engagement, particularly around BME inequalities, that we'll start to see improvements in relationships and therefore improvement in uptake as well for these sorts of things.
Lovely. We'll be seeing a lot more of each other then. Thank you.
Thanks, Matt. Judith, and then Vijay. And I think, Judith, everyone knows you, but Vijay, if you could introduce yourself to the councillors who may not know you and your role.
Yeah, thank you. So yeah, Judith Finlay, Executive Director, Children, Adults and Public Health. Just in case people don't know me. Thanks, Matt. I thought that was really helpful and great to show the vaccine hesitancy reducing over time. And we can see that in London too, with 85% of Londoners now saying that they either have received or will receive the vaccine. It's plateauing slightly at 10% in terms of hesitancy. So that's, that's a real task for us to grab hold of. And we're going to pick that up a bit in Anna's slides too later. We're seeing now that it's dropped to the age of 18, that young Londoners are hesitant too. So whilst adults talk about safety and a lack of trust in the system, as it were, and in the medicine, young people are more likely to say they don't think they need it. So we need to do some work on that simple, you do need it and don't wait type message. So I think that would be really helpful analysis to build on with your help, Matt.
Yeah, I agree. I think that sounds really important, particularly given the findings that we had in this report around how we need to kind of, which I'm sure everybody knows already, how we need to change our approach when it comes to young people. So those findings, in combination with the fact that they think, or the large percentage of them think they don't need it, means that we kind of need to think of different ways of going about it. And yeah, I'd love Healthwatch to be a part of that, definitely.
Thank you. Thanks.
And Vijay.
Good evening, everyone. I'm Vijay Taylor. I'm a GP in Acton. I'm the clinical borough lead for Ealing. Yeah, just Matthew, first of all, Matthew, this is a very comprehensive and detailed report looking at attitudes, and it really does reflect what we've been experiencing on the ground in terms of people's change in attitude to COVID vaccination. And certainly when the COVID vaccination was first rolled out, there was hesitancy and sort of uncertainty, and there were sort of comments around conspiracy theories about the whole idea of COVID vaccination and the experimentation that was being done on the public regarding the vaccine. But over time that did change, and then we had the rollout of the Pfizer and then the Astrazeneca vaccine. I think we did have a slight area of hesitancy when the Astrazeneca vaccine started to have the major blood clot issue with AZ, and the decisions that were made around Europe regarding AZ, and there were quite a few different changes and different opinions between the various European countries, which did also have an impact on the uptake of the COVID vaccination, and then particularly around which particular age groups should have it. And now, we in this country, we came to a consensus regarding, over 40s for AZ and under 40s for Pfizer. And I think once we got to that point, it became much more clearer for everyone to understand and appreciate what type of vaccine they should have, and the uptake started to improve again. I think the area for me where we still got to do some work is around the Afro-Caribbean population. I think that's one area where the uptake has been. I suspect it's still floating around between 40 and 60% in terms of uptake, but we have plans in progress to try and focus our uptake program over the coming 5 weeks. So hopefully we'll be able to improve that. And then obviously we will, across Northwest London, start rolling out the Moderna vaccine very shortly over the coming weeks. Again, and that will give again, there's another mRNA vaccine, so that will be open to all age groups above 18. So that will provide greater choice, and hopefully will reduce any further anxieties around the COVID vaccine.
Thanks, Vijay. Matt, was there anything else, other updates then from Health Watch?
There was, yeah, but I don't want to eat into anyone else's time, so I'm happy to send it round in an email, or if I've got 5 minutes, then I can whiz through it.
Anna has now joined us a bit earlier than I expected, so we don't need to stall for time. So if you'd like to email it round, and there's nothing urgent that you'd like to just update on, then we can move on.
No problem at all. I'll do that.
Brilliant. Thank you very much, and thank you again for the report, because it's really timely.
You're welcome. Thank you.
Anna, welcome. Do you want to take us through the COVID-19 update then? And then we can pick back up on some of the vaccination questions.
Yeah, thank you, Chair. Good evening, everybody. I'm Anna Bryden, Director of Public Health. Can I just check that screen's working?
It is flickering on and off. It has stabilized for me.
All right, I'll give it a go. If it fails, I apologise. Just wanted to run through an update on where we're at with COVID in Ealing. I am aware that we've covered similar presentations in a number of meetings over the last couple of weeks, so apologies for those where this is a bit of duplication, but wanted to share it with the board. So I'm just going to run through the normal national and Ealing situation, briefly talk about the Delta variant, so I'm just going to turn off my video if that's okay. Then run through our local action, so really about the vaccinations, testing, tracing, update on care homes, and Kerry's here as well, and just some key messages. This is a bit of a busy slide, but really important one, I think. So really wanted to show what the situation is currently. You'll see from the bottom left small graph, it's still relatively small, but definitely a significant increase in the number of people testing positive at a national level, going up about 35% a week at the moment. In the next two mini slides in the middle, you'll see that the number of deaths, fortunately, is still very, very low at the moment, but is starting to increase, but from a very low baseline. Similarly with hospital admissions, you're starting to see that as well. We're not really seeing that in London too much at the moment, but nationally you are starting to see a small increase. And then just over on the right, just really briefly, the darker blue areas are the areas with the higher rates at the moment. London is at the kind of medium end, but you'll see a lot of areas in the northwest of England, some in the Midlands, the southwest now as well. And also up near Glasgow are seeing quite substantially increased rates at the moment. So it will be interesting to see how that translates across the country in the next few days. And then, as most of us I'm sure will be aware, we're expecting to move to the next step 4 on the roadmap on 19th of July now. So we're still in step 3 restrictions, apart from some of the rules on things like weddings and commemorative events have changed, as well as some of the rules on things like care home visits. You'll have seen a limited number of pilot events are taking place about how to reopen these large events. So that includes some of the football matches at Wembley at the moment. And that will be really important learning for anything that we want to be doing in Ealing going forward as well. So just moving on to Ealing, the rate at the moment is about 92 per 100,000 people in Ealing. So that's just over 300 residents testing positive every week. That is pretty similar to London and England rates at the moment. And we're at the kind of middle part of London in terms of rates at the moment. We were down to a rate of about 30 per 100,000 for a while back, going back into May. But along with the rest of London, with the Delta variant, which I'll touch on in a moment, that has really increased. We're starting to see that very, very slightly decrease the last 2 days, but I'm not holding my breath yet or calling that a trend. But a lot of places across the UK, I was at a national meeting earlier and they're saying the same. They are seeing a kind of flattening off in a lot of places around the UK, which is a positive sign. And then we do touch on inequalities at the board. You'll be aware that over the course of the pandemic, we've talked a lot about some of our more deprived and diverse areas of the borough, particularly, say, for example, Southall being at the higher end consistently. We did see some of that when the Delta variant started, but now we're seeing much more widespread community spread. And we are seeing an awful lot of rates, an awful lot of cases, especially in the kind of younger adults age group. So very much that kind of 19 to 24. And I don't know if you can see the details of the graph, but the top blue lines are Acton and Ealing towns. And over the last couple of weeks, they've definitely been at the higher end, which is quite unusual over the course of the pandemic. Kind of trying to find out a little bit more what's going on there. It doesn't mean we've stopped any of our actions in any of the other areas. They're still ongoing, but the inequalities picture is a bit mixed at the moment. And then just in terms of deaths, I think really reassuring, although we've sadly seen a couple of deaths in the last few weeks, it's been very, very unusual. We really haven't seen those numbers being particularly high since about late April. We are starting to see, and I'll go on in a moment, we are starting to see, for example, a couple of small care home outbreaks. Unfortunately, we have had one death from there recently, but the numbers are very, very low and they are across the country. And just in terms of outbreaks, we show this each time. The numbers actually look quite similar to the last couple of times. So we've got 5 care homes at the moment and 6 schools. And 1 early year setting with an outbreak. However, I think really importantly, some assurance here is that with the vaccination programme taking effect, we are seeing those outbreaks, particularly in care homes, being much more, much smaller in terms of numbers and also much less complex. So we are, you know, unfortunately, there have been a couple of residents who have been more severely unwell. But on the whole, we are seeing people having much less severe symptoms, much less likely to go into hospital. So hopefully that will be the pattern going forward. And the same in schools, then nothing that we've got particular concerns about in terms of severity of cases or anything, and they're all being handled appropriately. So just wanted to touch on the Delta variant. So this is a variant of COVID that was originally identified in India and really is now almost entirely the variant that you're seeing in the UK. I think it's about 97% of cases now in London. So viruses change over time. That's entirely natural. It's entirely expected. Sometimes you get some variants that are a bit more concerning. The Delta variant has spread very, very quickly. In about early April, we got our first cases in Ealing. They were very clearly linked to travel to India and local countries as well. But now, similar to a lot of other boroughs across London, we are just now seeing widespread community transmission. So across all ethnic groups, all ages, and like I said, particularly in the young adults. Early data does indicate a higher risk of people being admitted to hospital if they test positive with this variant. However, we aren't yet seeing that translate into significant hospital admissions in Ealing or even more widely across the country, and when we are seeing very, very low numbers of deaths, like I said. I think one thing that's really important to take away about this variant is that the early evidence shows that vaccines are definitely effective against this variant, but that the second dose gives much more added protection than it would do for other variants. So really encouraging all our residents to get both doses is really important at the moment. And then because along with a lot of other boroughs in North West London, we were at the kind of earlier end of seeing this variant. We have just finished a 4-week period of surge testing. So we've had additional opportunities out there on the high streets, in testing centres and in a number of high schools, especially around Southall and Northolt. So really just a massive thank you to everybody that was involved in both organising that and really to our communities and families that were really willing to take those tests. And this was in parallel with a number of kind of surge vaccination activities, which I'll touch on in a moment. And then in terms of vaccinations, sorry, there's quite a lot of detail here. We have seen over 200,000 people having their first dose now, which is amazing. Along with a number of other, well, along with the rest of the country, we do see the inequalities in their uptake. So we're seeing it lower in more deprived communities, so particularly Acton for us in Ealing, among men, especially at those younger ages, and among people from mixed white and black Caribbean groups and other black ethnic groups. We have now got our main vaccination sites is CP House on Uxbridge Road in Central Ealing Broadway, and we've got 9 pharmacies around the borough, and 2 more will be starting in Ealing in the next couple of weeks, which is great. There's the vaccination centres, which were run by our primary care colleagues, have now finished their initial task with those first priority groups. But we are doing a number of pop-up clinics at Dominion Centre. For example, this last weekend, there were vaccinated, I think, about 1,800 people there, including a large number of people who aren't registered with GPs and potentially undocumented generally, and really reaching some vulnerable groups there. So just a reminder, anybody who's now 18 and over can either book or walk into one of our local centres, including CP House on Uxbridge Road. And if people have got a second dose coming up and they potentially want it earlier, just go and have a chat with a GP or walk into one of the vaccination centres and see if that's possible. We are doing over and above our normal vaccination sites. We are doing a lot of pop-ups and these surge vaccinations. So, for example, we've got extended hours. We've talked about Dominion Centre. We've got some events planned in Acton in the next couple of weeks, particularly. And we are also doing some targeted outreach in terms of homeless and unregistered people. So lots of work going on across the borough. We've also got, I think Vijay and Neha are here from our NHS colleagues. At the end, obviously, if there's any questions, I'm sure they'll be really happy to help around vaccinations. And then just a reminder in terms of testing, the testing landscape has really changed over the last few months. Lots and lots more opportunities for people to get tests. So if people have got symptoms and are going to get a test, there's 3 local testing sites that people can go to, and also they can order them to be delivered to the house as well. And I think for people without symptoms, we really are encouraging our residents to get tested twice a week. That's been shown as most effective in terms of picking up cases where people might not have symptoms but might still be passing it on. So it really is an important way to help protect friends and family. At the moment, we have got 6 testing sites across the borough and also 12 pharmacies. So if people want to go on site and get tested and be shown how to use them, that's currently available. From July onwards, we are going to maintain the local pharmacies, but close down the 6 testing sites and revert them back to their original uses. So, for example, the leisure centre and libraries. However, people are able now to pick up testing kits that they can use at home. That's from most pharmacies. I think our libraries also, we're going to try and have those there as well. And also people can order online and get them delivered to the house. So I think a real job for us is to ensure all of our communities are aware of those different options, really understand how to use them. And we are currently exploring a number of opportunities linking up with our community and faith settings. So not just about testing, but really about communicating that need for ongoing COVID safe behaviours, isolation if you've got symptoms, and vaccination. And then nearly at the end now, so just an update on our contact tracing team. Just a reminder that these teams, if somebody tests positive, they give them a call, have a discussion about self-isolation, ask them about people they've had contact with recently, and really importantly for us, signposting to local support. So our local Ealing team now carries out all contact tracing for anyone testing positive. None of our local residents are contacted now by the national teams. It's all done locally, which is great. And they're doing really excellent work, meeting all their targets and having a success rate of at least 90%. Over the last few weeks, we've added in a door knocking element. So some of our council officers, if somebody hasn't replied to a number of calls, text and email and a letter, they go out and just knock on the door, really importantly for older people as well, just to check they're okay, and try and support in terms of self-isolation, see what support they need. So we've done 14 visits like that so far and had quite good feedback and response from people on that. And that team's also been supporting with our vaccination efforts as well, which has been great, and also trying to be a super user for a new integrated tracing system that's coming online, so we can really volunteer to ensure that our local knowledge is being used to help across other boroughs as well. So Kerry, I don't know if you want to comment on the care home slide.
I'd be happy to, Anna, to give you a little break. Is that okay, Chair? Yeah, just to introduce myself, my name's Kerry Stevens. I'm the Director of Adult Social Care. Ealing's got the 5th highest number of CQC registered care homes in London and the highest number of beds in North West London, just under 1,600 registered care home beds within the boundaries of Ealing. Throughout the pandemic, the council and their partners have been working closely together to ensure we have a consistent response and support to the care home sector, and the group has met on is now meeting on a monthly basis. But during the height of the pandemic, we were meeting twice weekly to ensure that we were providing support and having oversight of the sector. It should be noted within the care home sector within the borough, we're currently operating with 20% plus voids, which is a real challenge in terms of the viability of the sector. And this is something that we're working with London ADAS and the London School of Economics to have oversight of the impacts of the sector due to the pandemic. As of Monday the 14th of June, there was 1 care home closed due to outbreaks. We negotiate with care homes to close where there's been a significant outbreak. We're unable to enforce closures, but we've been successful in negotiating closures with care homes to new admissions throughout the pandemic. And sadly, there's been a further 2 reported deaths in the last 4 weeks due to the Delta variant. Of the residents in care homes, 93% of residents have received their first dose of the vaccine and 88% the second dose, whereas care home staff, 79% of staff have received their first dose and 60% their second dose. It's widely indicated, and we're expecting new legislation to become law in August of 21 with regard to mandatory vaccinations of people working within the care home sector. And there's a huge amount of work on this at the moment in terms of what the impacts of that will be. And I believe we've got a question on this later on the agenda today. Thank you, Anna.
Thank you, Kerry. And then just to finish off, I have got a further slide that we'll publish with the page that's got a lot of web links. So if people want to look at those in terms of the key messages and where to find out more information, they're available. But I really just wanted to go through this poster here. They're really key messages. So if anybody's out and about talking to the community, please do share these. We've got an awful lot of social media resources and leaflet resources on our website and in lots of different languages as well. So really encouraging residents to, as society opens up especially, and as infection rates are unfortunately increasing at the moment, these are even more important. So washing hands every time you're going out and coming home, covering your face where it's needed, giving each other space, so carrying on with that social distancing of 2 meters, and opening windows, getting good fresh air in. I think one thing that's really important, and only as a part of a whole package, is taking these free rapid tests twice a week. About a third of people with COVID don't have symptoms, and so this is really to help protect you, your friends and families. And for every adult that's able to get a vaccine now, please do take them. There'll be people at the clinics, at the vaccination clinics, who can help answer any questions. There's lots of information in terms of myth busting, concerns, practicalities, in terms of Q&As on our website as well. But I think really important, please do come to a vaccination site, whether you book, whether you turn up, you'll be very welcome, and people are very happy to have conversations with you there. So Chair, that's the end of presentation, but very happy to take questions now or later. Thank you.
Great, thank you, Anna. I was going to suggest that we take relevant questions now, so we don't kind of leave everything waiting. So if members can put up their hand, I will take them, and then there are a couple of questions from the public which we can cover now as well. Councillor Conti, and welcome back.
Oh, thank you. Yeah, so I'm Fabio Conti, I'm Shadow Portfolio Holder for Health and Adult Social Care. I had a couple of questions, if that's all right. So just a couple on sort of one on testing. On the key messages, I wonder whether something really to push is the importance that if you are symptomatic, about the importance of getting a PCR test, because I think there is a growing misconception amongst people that doing a lateral flow test at home is enough. And we know that they're obviously not accurate enough in people who have symptoms. And I think that message isn't out there enough. And I think that may be something that probably does need pushing. In terms of the sort of contact tracing, I know obviously we're doing that locally in Ealing as well. I was wondering what the sort of communication between local and national contact tracing is. I was speaking to someone the other day who, a couple of weeks ago, they got 12 calls in one day from different people contact tracing. And I was just wondering, is that linked up so that, also for efficiency in terms of people not getting multiple calls? And then my last point was just on sort of compliance sort of with COVID regulations in local businesses. I was wondering sort of how that's going, whether that's being monitored. I know probably come the 19th of July, that's probably not going to be as important, given there probably aren't going to be any restrictions. But is that something that is being monitored, and what's compliance been like sort of so far?
Thanks, Fabio. Anna, do you want to pick up on those as best you can? I'm not sure if you can answer on the regulatory point, or whether we can get someone else to respond to Fabio offline.
Yeah, I'll give it a go. Thanks, Councillor Conti. So in terms of testing, that's really useful feedback. It's not something I've really heard before in terms of that, but I think we do carry on pushing with our general messages, and have done all the way through. So both through our communications route and through our community engagement teams as well. The importance of that testing when you've got symptoms. I think LFT definitely isn't enough. Definitely encouraging people to get testing. We've still got our 3 local testing sites, which is great, and people can get them online. But I will take that back to the comms team in terms of some additional pushes and really understanding concerns about that. Contact tracing. So we now in the local team do this entirely ourselves. There's almost nothing done at the National Tracing Service. And we have put in processes where the local team groups up families of household contacts so they don't get multiple calls. Chair, we've got Chris Bunting on the line. I don't know if Chris wants to add to that, because obviously he's leading on that team.
Good evening, Chair. Chris Bunting, Assistant Director for Leisure, currently Lead Officer on the Council's response to contact tracing. I think you've summed it up perfectly there. We took over the national role on the 2nd of April, seems like an age ago, and I think that has absolutely reduced that multiple call. So that's what we're hearing, and actually the engagement with our local residents because of the local calls has meant that our performance has gone up, and we're now meeting over 90% of our cases. So a real positive story there, Councillor.
Thanks, Chris. Anna, can you say anything about the regulatory side? Or
yeah, I'll ask the team to feedback to you, Councillor Conti, if that's okay. So we have sit-rep meetings on COVID 3 times a week, and we meet with the regulatory service all the time. I'm not aware of any particular major concerns, but we do have an email address and a phone number if people do have concerns. And the team does both very much kind of proactive, going out, talking to businesses, doing regular liaison, supporting, giving out assets, and also reactive work. So if anybody does raise concerns, they can go and visit premises and have that conversation. But I could definitely get you an update over email if that's okay. Thank you.
Thanks.
Yeah, we have definitely extended the COVID marshals that we had up to the end of the 19th July, as it currently is. But obviously, as Anna says, that's reviewed kind of almost daily, but certainly weekly when we meet at Gold. VJ.
Yeah, I just want to echo what Councillor Conti said, and around the misconceptions about lateral flow tests and asymptomatic versus symptomatic. I've actually raised at the ICS level today because it's actually, there is a significant misconception out there, and I've sort of first-hand experience from patients I've spoken to who believe that if they have if they've got symptoms and have a negative lateral flow test, they can carry on as business as usual. So I think we do need to work on some public communication and comms around the difference between PCR and lateral flow test and what should be done at what stage. I think there is an issue out there that we need to address now, I think.
Thanks, Vijay. And if you just hold on a second, we did have a question on lateral flow testing from Clara. So Clara, if you wanted to ask that now, and then Anna, if you respond on that and the messaging.
Okay. The lateral flow self-testing in the hands of professionals only gives 80% positive results. Thus, there are about 20% false negatives. Worse, in the hands of the public, this falls to about 60%. In other words, the test yields 40% false negatives. For epidemiologists, information in the test can be useful, but on an individual basis, it gives erroneous information. Why are you continuing to advise the public to perform a tedious, unpleasant test that gives false reassurance?
Thank you, Clara. So I think it's a really good question. I think there's been a lot of misconceptions about what the lateral flow tests are, how they're used, how useful they are on their own. They aren't a standalone answer to everything on their own, like every other COVID measure. So the community testing that we do is just for people without symptoms. It's really beneficial for a lot of people in terms of being easy to use, being easy to store, giving results in about 30 minutes. And for me, the importance is really to pick up those infections early where people don't have obvious symptoms or very mild symptoms. So really helping to limit the spread. And I think the important thing for me as well, and what I really usually try and emphasize, is that these are people who otherwise wouldn't be tested for COVID. So it really is about case finding. Anybody receiving a positive test with one of the lateral flow devices should still take a follow-up PCR test to confirm it. So we ask them to self-isolate if they're positive, but we do say get a follow-up PCR, and they'll be able to do that quite easily. It has undergone extensive clinical evaluation, and it's judged to be accurate and sensitive enough for asymptomatic community testing. Like with every single test, it's not 100% accurate. So someone testing negative can still be infectious. And so we always try and give out the messages about continuing with social distancing, hand washing, etc. Since we started with the rapid tests in Ealing in January, we've had about 1,100 residents in Ealing testing positive via a lateral flow test, which is about 7% of our total. So for me, that is 1,000 people testing positive, hopefully self-isolating, protecting people that otherwise wouldn't have been picked up. And I think importantly, our messages out to the community via both our communications and our engagement routes are really carefully crafted to really ensure that people don't think that LFT testing means that they can go out and do anything that they wouldn't be usually doing under the restrictions and the guidelines. So it's really still important for everyone to continue with that COVID safe behaviour and get vaccinated. Thank you.
Can I just
Thanks, Anna.
ask? Can I just ask, what's the evidence? Because the Americans don't recognize this test and do not think that it has been adequately analyzed. I haven't seen any analysis of how competent this test really is. Have you got it?
Thanks,
So
Anna.
I've seen it from National Public Health England documents that were done at the beginning, and they have continued to build on that evidence. If it's all right, Chair, I can try and find a couple of those links and dig them out again and share them if that's okay. But I think it's important to understand we are following national guidelines on this, and this is very much a national government drive and something we are supportive of. But importantly, only one part of all of those package of behaviours together. Thank you.
Thanks, Anna. There were then a couple of questions on care home staff. There was one from Mike, whose name I can't see. So Roy, you had a question on vaccination of staff in the care sector. If you wanted to.
Yes, hello there.
There you are. Sorry, I lost you on my screen. Roy.
Yeah, can you hear me? Yep.
Yes.
Thank you. I'm Roy Willis, chairperson of Ealing Reclaim Social Care Action Group. So we did have a question about the level of vaccination in the care of staff in the care sector. I thank Anna and Kerry for some of the information that's already been given. But I think we do want to find out if vaccination for these groups is still progressing and what measures and incentives could be implemented to increase the vaccination rates of social care staff, not just residential staff, but all domiciliary care staff and daycare staff, and trying to reach up to the 100% mark, because obviously social care users in residential care and in the community remain at risk if their carers have not been vaccinated. So I don't know if there is any new measures or incentives that you're thinking of bringing in the near future for these groups of staff.
Great, thanks, Roy. And then the other question was then about opinions on the mandatory vaccination. So Kerry, did you want to pick those up?
Yeah, thank you, Chair. In terms of, Roy's absolutely right, and we've been discussing this for throughout the availability of the vaccines and how to encourage and work with people working in the care sector. I've given you the figures already in terms of people working in the care home sector, but just to update in terms of people who work in the domiciliary care sector, first dose in Ealing is 77% and second dose is 52%. In Roy's question, he recognises that London is lagging somewhat behind the rest of the country, but overall Ealing's performance is strong, and in the vast majority of areas other than second dose for people working in care homes, we're above the average, and for people working in the domiciliary care sector, we're in the top quartile in London in terms of performance of vaccine. Roy, we're continuing to work and keep in close communication with the sector. The DHSC have targeted some care homes with lower than 50% vaccine rates, and the councils work very closely with those providers to improve their performance. I'm happy that the performance is continuing to improve and people are continuing to come forward for the vaccine, but this doesn't mean that we can take our foot off the accelerator on this. It's a constant challenge, but some of that's to do with the turnover of staff within the sector, so it's a really important area, and we are continually working with colleagues in the provider sector to maximise the vaccine uptake. Is it okay to move on to the mandatory vaccine question as well, Chair?
Yeah, please do.
Thank you. So, and thank you. That is Mike asked this question. This is absolutely a key topic for us at the moment in terms of within the council, across the London directors of adult social care groups, and also working with unions and with the provider sector. Our current understanding is that the requisite changes to the law will come into effect in August 2021, but there'll be a 16-week grace period to allow
individuals to be vaccinated. After the 16-week grace period, the Care Quality Commission, who are the registration authority for care homes, will be responsible for ensuring that care home workers are vaccinated and monitoring performance against that. And it will be down to individual care providers to have oversight of the vaccination of their staff and that they meet the requirements of the law. In terms of a view, this is a really complex area. I think there's civil liberty issues here, but there's also issues about protecting some of the most vulnerable people within our society. We need to take into account the impact that the pandemic has had on people in care homes who we know were disproportionately affected by the vaccine. We need to take into account the impact of the vaccine rollout into the care home sector and the significant improvement in the lives of people living in care homes as a result of the vaccine programme. We also need to take into account the impact of Brexit, because we know it's very difficult to recruit staff in certain areas due to Brexit, and also what the double whammy of Brexit and mandatory vaccination may have on the staffing capacity within the care sector. And that's something that we're keeping a very close eye on. And obviously in terms of recruitment and retention of staff, as well as the legal frameworks around what happens to staff who haven't been vaccinated and where they stand in terms of employment within the sector. The changes as law are seen as a benchmark in terms of how the wider application of the approach will be applied to other sectors, potentially including the NHS and the home care provider sector. So that's something we're very alert to. And from a council officer perspective, we're working very hard and very closely with the provider sector to minimise the impacts of the application and the changes to the legislation to the people in the care sector and the care homes. Has to be absolutely central to this piece of work. Thank you, Chair.
Thanks, Kerry. I'm conscious it's 7 o'clock and we have 3 very big reports, very important topics on the agenda. Peter, did you want to say anything just about vaccinations and the council's role? And then we'll move on to the integrated impact assessment.
Thanks, Chair. And that was sort of my prompt to probably be as quick as I can on this. Obviously, sort of since taking over as a new administration, this has quite literally been our sort of top priority. Of course, we discuss all of the various other bits and pieces that we're working on, but Councillor Blacker and I, as well as sort of the rest of the team, certainly have been sort of locked every week in both our gold meetings, but also our conversations with NHS partners around vaccination. Of course, when you look at the national picture on rates of vaccination, Ealing, whilst we look good in terms of London, being sort of right there in the middle, in the average, sort of when compared to the national rates, we are sort of behind where a significant number are. Obviously, that probably has more to do with London's demographics being younger than the rest of the country, and much more to do with JCVI's cohorts in terms of both our access to vaccine and the cohorts that have been able to access it. And sort of picking up, Clara's point on the sort of purpose and efficacy of testing. Of course, we need to make sure that we follow national guidelines that are given to us to make sure that we're encouraging people to take tests, whether symptomatic or not. But of course, taking the tests will help us track. It won't help us defeat. And that's the purpose of vaccinations. And of course, as we sort of now move forward into a situation where there isn't really, certainly above the age of 18, any reason why we shouldn't be working very, very hard to get those vaccination rates up. And we've got to make sure that that trajectory goes in the right direction. That's the nature of the conversations that we have each week with NHS partners. Some of that's not in our control. The policy decisions that get taken about the quantum of vaccine and where that vaccine goes are not decisions taken locally by certainly anybody on this call. I think it's worth and important. It's worth bearing that in mind in the discussions that we do have around this topic. But nevertheless, we will work pretty much around the clock and very hard to ensure that we're getting the messages out to the community that vaccination is the key thing that we need to be doing. And really to say thank you, and we can't say thank you enough, to the clinicians and the allied healthcare professionals and to the managers who are making this happen and making this work. There will be a point in the future Probably it won't be until after booster shots, and it probably won't be until after the winter, where I think people probably will, hopefully at some point, be able to breathe and to take a bit of a rest and sort of look back over this period and realise just how much of a Herculean effort it's been. Thank you, and that's me.
Okay, thank you. Simon, did you want to say something just on COVID then?
Yes, please, if I could. So Simon Crawford, Deputy Chief Executive Director of Strategy at London North West Healthcare Trust. Just to comment really around the number of admissions that we've got with COVID currently, just to provide some reassurance really, in the sense that at Ealing today, there are 2 positive patients within the hospital. Over the last sort of 8 weeks or so, it's fluctuated between 2 and about 7 or 8 max. But at 2, it's as low as it's been, I think, over the last 6 to 8 weeks. And equally at Northwick Park, we've only got 7 COVID positive admissions within the hospital at the moment. And again, that's fluctuated again over the last 6 to 8 weeks between probably 4 to about 16 max. So at 7, it's relatively low. So I just wanted to share that with the committee.
Brilliant, thank you. That's really helpful data, given the context of, particularly the Delta variant. So I think, reinforces the message that vaccinations are the key to getting through this. So thank you. Anna, is Maddie, are you taking us through the integrated impact assessment?
Yeah, Maddie's going to take us through, Chair, if that's okay.
Fantastic. Maddie, over to you, because this is a fantastic piece of work.
Thanks, Chair, and thanks, Anna, and good evening, everyone. I'm just sharing my screen, just bear with me a second. Okay, so there we go. So yeah, good evening, everyone. My name is Maddie Gupta-Wright. I've met a few of you before, but I'm a consultant in public health in Ealing in Anna's team. And I'm here tonight to give you an update on the integrated impact assessment work that I now lead on for the council, but which is really a cross-council effort. As it's been a little while since we presented an update on this work, this is just to remind you of all the context and the aims for this. So recognising that COVID as a pandemic has exacerbated existing health, social and economic inequalities, the aim of this work has been to assess a wide range of complex and interrelated direct from the illness and indirect from the restrictions impacts of the pandemic upon Ealing's population, and in particular to understand who's been most significantly affected and how this compounds already existing inequalities, but in addition to identify those assets and opportunities for recovery where we can make improvements within the system long term to enable a more asset-based approach to work across the whole system on inequalities. And ultimately, the piece of work has been to make a series of recommendations in themes for short, medium and long term to influence a number of key council and integrated care partnership actions, strategy and policy. So the process has involved multiple different components, including quantitative data analysis on COVID direct and some indirect impacts, combining that with information in national, regional and local literature on the impact of COVID, and an element of limited but extremely valuable community engagement and consultation. And the whole process has been guided by a cross-council steering group with directors and assistant directors from across the council involved, and that group has been shaping the recommendations in each of the areas. So each themed set of recommendations will be owned and overseen by various specific boards, groups, forums, depending on the topic. But the idea, of course, has been for us to work together as we recognise that people themselves haven't experienced these impacts in these discrete themes, but as a whole. And there are many points of influence for this work, most notably the Health and Wellbeing Strategy Refresh for 2022-2027, the Council Plan and the development of the Integrated Care Partnership priorities. So national and regional literature, particularly the Public Health England Disparities Report, highlighted the following greatest risks for COVID, particularly severe illness and death. So these are on in the first column from the literature. Those are age, a higher age, anyone with a long-term condition, those living in greater deprivation, Black, Asian and minority ethnic groups, those in urban areas and those working in frontline occupations. So those were the key greatest risk factors for COVID identified by the main national and regional literature, particularly the Public Health England Disparities Report. So next to mention in the other column from Ealing data, the main findings from the quantitative data for Ealing from March 2020 to 2021 echoed very much of that found in the Public Health England Disparities Report. Whilst working age adults were most affected by infection, the vast majority of those admitted and who died were in older age groups, and a very large proportion of these people sadly had had long-term health conditions. The data suggests an unsurprising relationship with poverty, with the highest infections concentrated in the west of our borough, and both hospital admissions and deaths being distributed in a gradient across the borough, which is likely to be attributable to broader social factors, societal factors, such as deprivation. Wards with higher proportions of residents identifying as Black and Asian or minority ethnic groups had also got higher total infection rates. And Asian British groups appeared to be disproportionately affected by hospital admissions for COVID. Now, the caution with the ethnicity data is we aren't able to clearly separate all the many other conditions at play when we look at the relationship between ethnicity and impact from COVID with the data that we have. But that said, when national and regional literature have done this, the conclusion has been that even when you adjust for things like deprivation and other living conditions, there is still an effect attributed to ethnicity, which has been put down due to structural racism and structural discrimination. We are a relatively overcrowded borough, so the Ealing data also tells us that, and that will of course have had an impact on people's experience of COVID. We also do have a higher proportion of residents in the lower skilled elementary occupations, and therefore facing the front line and greater COVID exposure than some other areas. So just to give you some highlights from discussions we had in area task group meetings in March as part of the community engagement and consultation that I mentioned. So these were 4 meetings with community leaders and councillors from each of the following 4 areas. And the next 2 slides give some of the highlights from those discussions. So these were reflective discussions, independently facilitated, to have a conversation about what people thought caused the exacerbation of inequalities in their particular area, and ideas for collective action to tackle these, again, focused on those 4 areas. We took this approach because the groups had already been working together throughout the pandemic and established a degree of mutual trust. And because this seemed the best way to give the limited circumstances for a more, given the limited circumstances for a more comprehensive process of community engagement, to engage in conversations about inequalities with people from different geographical parts of the borough. So some of the highlights gleaned from these meetings are here, and you'll be able to digest this detail in the slides shared, but just to highlight some of these highlights. So for Acton, people felt there'd been insufficient engagement in their area, and therefore regional inequalities had developed, and they didn't feel the system had treated them as a whole. One suggested solution was to revitalise an asset-based approach, realising their community power and assets and utilising them properly and working with people of Acton. For Greenford and Perivale, some of the inequalities worsening were directly attributed to a loss of important infrastructure, community centres closing, etc., and the wider impact of the charity sector's funding difficulties during the pandemic. And they highlighted that digital exclusion was also about the fact that some people found it very difficult to express themselves online virtually, and that it wasn't going to be just changed or helped by software or hardware. And repeatedly for Greenford and Perivale, racial inequity and attitudinal discrimination was identified as an important cause of the inequalities. So for Northolt, the inequalities were attributed quite strongly to a lack of sense of place identity due to a feeling of neglect of Northolt infrastructure and the urban realm itself, and the fact that people didn't feel a part of Ealing. And they particularly highlighted the need for better and new physical places to meet, get support, interact, and develop a stronger sense of their community. And for Southall, there was a strong will to continue the good work of Ealing Together, but consider the possibility of a more hyper-local version of this for Southall. People felt there was a need to localise planning in the area so that homes reflected what the population of Southall needed, as they felt that this had otherwise widened inequalities for people in Southall during the pandemic. They wanted more attention to a hyper-local, place-based needs assessment, development of strategy and policy overall. So just to give you a flavour of the recommendations, they are structured in the following themes, with work which is ongoing in several of these themes to finalise these and confirm the ownership within different partnership boards. You can see the themes listed here, what the progress is on each of those themes, and the governance and ownership that's been decided or being discussed at present. So you can see the wide range of themed recommendations and just how much of a cross-system and whole system piece of work this is. So to go into a little bit more detail on some of these recommendations, but to keep it to the highlights. So the next slide looks at the first theme, which is actually a cross-cutting theme for us as a system, a council, and hopefully an integrated care partnership system. And this is a long-term set of recommendations. So these are principles of working which we feel should be recommended for all of us in order to proactively tackle and prevent further inequalities. So for community participation and ownership, that's about taking a real, truly participatory model and having that at the heart of all council policy, strategy and action, including a very strong emphasis on co-production. To galvanise opportunities of major transformation in the ICP, ICS as an example, to embed a whole systems approach to tackling inequalities, making sure that we have an asset-based approach, not a deficit focus. So looking at really the assets within the community groups and reaching out and working with communities to make best use of those assets to tackle inequalities. The next was a take on a concept that was coined by Sir Michael Marmot, whereby we need a universal offer of support, which is always scaled in proportion to need. And that was identified by his huge amount of work on inequalities as a way of evidence-based way of tackling inequalities for services, policy, and so forth. Important principles of working around the re-emphasis on tackling structural racism and embedding equity and fairness, prioritising this hyper-local, place-based approach, which came up very strongly from several of the area-based task group consultations and also in literature. Having a more one-stop shop front door for residents, which did offer that multidisciplinary team approach so that people felt that their needs were being addressed holistically. Working across the life course so we ensure early prevention and early intervention of health problems and social and economic inequalities. Again, to identify those root causes of inequalities so that we're working on the wider determinants of health and before things become a problem. Important that through this work, it was raised and considered an important principle of working that we incorporate action to address the climate and ecological emergency in all of the work we do, as this will only further exacerbate inequalities. And we know that the impact of any climate and ecological emergency events will fall greatest on those already experiencing inequalities. To use and create the evidence base for continued good practice, and to lobby to tackle poverty, as poverty is, of course, one of the largest and most significant determinants of inequality. Just to give you a flavour of the recommendations in the themes, I won't go into this in detail, but I've put in bold the ones I want to mention. So for the theme of housing, gives you a sense of the kinds of things that are coming out. So creative planning direction requiring all households of multiple occupancy to apply for planning permission. For children and young people, there's a recommendation to monitor an attainment gap and plan to reduce short and long-term effects on most disadvantaged children, and to re-establish Ealing Children's Partnership with clear focus on addressing inequalities for children and young people. Apologies, I realise the version you're looking at doesn't have the bolding on it, but I will circulate these slides so you can look at all of these recommendations or the highlights of these recommendations in detail. For mental health, there's a recommendation around developing a strategic approach to living with COVID, focusing on mental health and wellbeing resilience and linking closely to the social prescribing landscape. For the area of active living, active ageing and adult social care, there's a recommendation to ensure all commissioned care and support services are working on the London Healthy Workplace Award and are adhering to the Ethical Care Charter for London, including the London Living Wage to all staff. And just to give you a flavour of the kinds of things coming out in the digital inclusion theme, we have a recommendation to develop a model for customer contact, which prioritises prevention, early intervention, holistic support through that multidisciplinary team approach, but also making sure that there's a hyperlocal face-to-face support offer, which makes best use of existing real estate and also offers an opportunity to digitally upskill residents at the time as well. So the last slide is just to show you our intended next steps with this work. The work is ongoing with the steering group, hoping to meet next in July to finalise the recommendations and work towards producing a final report end of July into August. There's ongoing relational and engagement work to do with partners, and particularly as the Integrated Care Partnership develops further. And it's our intention that this work will be summarised into a more reader-friendly annual public health report in order to communicate with a wider resident audience in the borough what this process has found and what the recommendations are. And then lastly, in the box there, so it's our intention for this to form the basis from which to build the health and wellbeing strategy refresh for 2022 to 2027. So we're proposing that it is along the theme of addressing health inequalities and building community wealth with whole system thinking. And that is therefore able to focus on these key areas, and particularly some of the principles of working informed by the integrated impact assessment that I've listed there. So I'll stop there, but very happy to receive comments or questions. Thank you, Chair.
Brilliant. Thank you, Maddie, and the team for all the work on that. Peter.
Sorry, my screen just did something funny, but I think I'm okay. Am I there? Am I there?
You are here.
Great, thank you. And thank you to Maddie for that piece of work. I think what it does is reflect one of the things that the administration set out very clearly in terms of our sort of new priorities emerging from the new context of COVID, the climate crisis, and of inequality, that we absolutely have to take a laser-like focus on particularly the parts of the borough that have been hardest hit by those challenges. But also, Maddie mentioned it, proportionate universalism. Part of the challenge in this space is that we have always known that there are wider determinants of public health, and we have always known that poverty and exclusion and the lack of decent living incomes is a fundamental driver to poor health. And it strikes me, and I've talked about it quite a few times, that we know that there is a direct correlation between the lack of decent incomes that causes situations in which life expectancy in Norwood Green is, for women, by the way, is sort of 15 years less than it is for women in Northfields. And we know that there are structural things that we can do to be able to make a significant impact. Some of those are in the gift of local government. Many of those things are in the gift of national government, but we can't do any of those things without a concerted effort to try and focus very clearly on those priorities. And I'd hope that this piece of work, as it goes forward in terms of internally within the council, could also bring in our partners, not just in the NHS, but I think the whole public sector, private sector too, really to focus in on the areas that we need to focus on. And for me, some of those themes around community identity and place-based approaches to sort of how we do some of that work, and giving people sort of confidence and hope that things can change and they will be different, and that they can see the sort of the direct impact in their locations is absolutely vital and important to that. But to commend the work, and look forward to seeing how we take this forward.
Thanks, Peter. Are there any other comments and questions then to Maddie? Sarah.
Yeah.
Hello, hi, I'm Sarah Rushton. I'm the Operational Director from West London Trust, and I'm also the Director of the Ealing Integrated Care Partnership. It was a really useful and helpful presentation, and I think there's a lot more that could be done to join this up, though, with the Integrated Care Partnership. It still felt a bit like very much a local authority-led way of looking at it, and I think we need to bring that health element in as well, because that way, I think if we join it together, we can start to tackle some of those areas, both in health and in the wider local authority. So yeah, I will have a discussion with Anna about how we do that and how we perhaps get better reach and get it out to some of the primary care networks and some of the local areas where people are on the ground trying to tackle some of these issues every day through health.
Thanks, Sarah. And Simon.
Yeah, just to build on what Sarah said, really, the two things strike me is one of the ambitions of London North West as a trust is its role as an anchor organisation in the community it serves, and I think there's a lot of opportunity in the things that was described where we could work with the council. So certainly in terms of the areas of employment, certainly supporting local businesses, around procurement, things like apprenticeships and training. Those are all rich areas that we would be happy to explore with the council in terms of how we could support those. And the other one that struck me was around the digital agenda. So certainly in health, we're planning on sticking with some aspects of the digital agenda in terms of electronic booking of appointments and meetings, but also in terms of consultations and that kind of stuff. So understanding the level of need in the community in terms of how we can reassure or support people that this is an appropriate medium going forward, I think is quite important. And certainly I'm sure it's the same with GP consultations as well. So again, joining up health and local authority around the digital agenda and the training and support, I think would make a lot of sense to me.
Great, thanks, Simon. Judith.
Yeah, thank you. Just briefly to confirm that I agree with Sarah's reflections on that. We spoke about the council rather too much, so this is very much for us as a community of partners. We'll bring it to the next Integrated Care Partnership Board so that we can build on it from there. Thank you, though, Maddie. It was very helpful.
Okay, I think, Maddie, the proposal was that this forms the basis of the health and wellbeing strategy. And our, the refresh of that. Are members then happy that that is the approach we take? That we will come back to it under the work programme, I'm sure. But
and Chair, if I may as well,
Peter, yeah.
As I say, Maddie's sort of taken us through some of the under the bonnet work on this in terms of preparation. But some of the work that we're going to be doing, for example, around the local strategic partnership is about really focusing on that agenda of inequality, not just in the health context, not just in the public health context, but more broadly. And some of that work, I think, is going to be reflected across. And both if we're able to pick that up at the Health and Wellbeing Board, and I know that there are people on here, Sarah, it's good to see you, on the local strategic partnership as we sort of really embed that in the work that we're going to be doing over the next year. Looking forward to sort of making sure that this is the heart of the conversation that we have with everybody in the public sector or the private sector, and not sort of just keeping it sort of inside Percival House, because it's a big world out there, and it's going to take all of us to sort of do something about those wider determinants.
And equally, I'm sure there'll be some recommendations coming from the Race Equality Commission that will be relevant as well. So I think it's particularly timely work, and as Peter says, is one of the administration's key focuses in many areas. Okay, so let's move on. I mean, in talking about tackling inequality, I think we can move on to Let's Go Southall, which is probably a very good representation of how that gets put into practice. We have Chris Bunting. We also have Councillor Jasbir Anand, who is the cabinet member responsible. Jasbir, do you want to do a quick introduction and hand over to Chris, who can then take us through his report?
Okay, Chair, thank you. I'm bringing good news stories, Chair, to your panel. My name is Councillor Jasbir Anand, and I'm the portfolio holder for Thriving Communities. Chair, the report before us is an excellent good news story for the borough, and of course, most importantly for Southall, which is a Sport England local delivery pilot Let's Go Southall funding award. Chair, this report was agreed at Cabinet on the 16th of June, and we considered the plans to allocate around 2.3 million of the funding from Sports England as part of the next phase of the Let's Go Southall project, which seeks to get local people active and tackle some of the issues of public health we have in Southall. We've made some real achievements in increasing physical activity in the first phase of Let's Go Southall, which is why Sports England have provided us with the further funding, and we're proposing to use this funding in a number of ways, which is including the installation of 3 state-of-the-art outdoor gyms in Spikesbridge Park, Southall Recreation Grounds and the Manor House grounds. This is going to be available to everyone in the borough, and in particular to the residents in Southall. We'll also be investing in 2,500 bicycles, starting with the initial phase of 500, which local people will be able to apply for free if they are currently on low sort of physical activity, don't have access to bicycles currently. And they are prepared to commit to using the bicycle at least once a week and undertake cycling proficiency and basic cycle maintenance training. Chair, we've also received a grant fund to create a social movement called Active Communities Team. And we really want to use this as an opportunity to break down the barriers, as we've all been talking about, through active travel and physical activity in Southall, to give people an alternative to driving for short journeys, and also provide access to high quality equipment to help with this for everyone. As we spoke about the life expectancy, Chair, a stark contrast that can lead to living a much shorter life. People living in Perivale will on average live 7 years longer than people in Southall. Chair, Let's Go Southall mission is to make it easy for people in Southall to get the active as part of their daily lives. And Chair, can I also take this opportunity to thank Chris Bunting, Jasper and Reginda and the rest of the team for making and leading on this bid and making this a huge success for us. Thank you, Chair.
Thanks, Jasper. Chris, do you want to take us through your slides and we will hear more? It's a fantastic piece of work, so I echo Jasper's congratulations and thanks.
Thank you, Chair, and thank you, Councillor Anand, for those kind words. I'm just trying to share my screen now. Hopefully you can see that, and no. It's telling me it's sharing. I
can see ourselves.
I will go back to the start. Can you see that now?
Yes. If you could just pop it on slideshow mode so we can see it a bit bigger.
Okay, can you see that on slideshow? Thank you. Once again, thank you, Chair. Thank you, Councillor Anand. I'd also like to introduce you to Rajinder Singh, who's on the call, and will share the responsibility of taking you through the slides this evening. Just to give you the context, there's actually 5 logos on that screen. The first one is Let's Go Southall, which is the brand of the programme. The one next to that is the Active Communities team, and that relates to the social movement that's been created to promote physical activity in Southall. So that's the unique selling point of Let's Go Southall, as seen by Sport England, is around the creation of a social movement. The social movement is very much around a community-led approach to getting people to be more physically active as part of their everyday lives. And you'll recognise the Ealing Council logo. And the programme was very much a traditionally led programme, led by Ealing Council officers. And I think we spent quite a lot of time scratching the surface to try and get under the skin and under the inequalities that exist in Southall. And I think the programme has taken a real leap forward in terms of working with a community-led approach with the social movement. The National Lottery and the DCMS are funding Sport England with a significant strategic programme called Local Delivery Pilots, and this is one of them. Goes without saying that there are stark inequalities, and we've referenced about length of life, but as part of the programme we conducted a baseline survey with 700 Southall residents, which confirmed that at least 43% were what is classed as being physically inactive, doing less than 30 minutes exercise per week. And this contrasts significantly with the borough-wide figure of 27% and the national figure of 25%. So the baseline survey work certainly identified that we are working in the right place. And when we went through the bid process with Sport England, it was understood that if we can tackle physical activity in an area with the highest levels of preventable and chronic health in the borough and in London in many respects, then we can probably tackle that anywhere in the country. So this is a really important programme for Sport England. The Health and Wellbeing Board actually forms part of the governance of this programme, and attendance has been light touch to date. However, with the very exciting and significant progress that we've made in recent times, culminating in the Cabinet report, and as we move out of the incubation of the project, we feel now is the time to more significantly engage with the Health and Wellbeing Board. As I've said to you, Southall was one of the 12 pilot areas nationally. To give you again context, some of the others are Birmingham and Solihull, Greater Manchester, Essex, Hackney, Calderdale, and they're all different in their own ways and size and scale and demographic. But actually, we've been working with Birmingham and Solihull around an aspect of the project where there are similar demographics in play, which has led us to work collaboratively with their bike programme as well. And as Councillor Annan said, the essence of this programme is to make it easy for people to get active as part of their everyday lives, so that it becomes a normal way of meeting their wellbeing needs. We also, at the outset, 2.5 years ago, talked about supporting people to walk more, to cycle more, and to try and make sure that all short journeys are either walked or cycled instead of driving, and to get more cars off of the road. And also, we know that by getting people more physically active, it will also support their overall social and economic well-being, as well as increasing their health and fitness. Also, again, in hindsight, actually talking about getting people to be more active and connecting them to their neighbours is actually exactly what we're trying to do in terms of the social movement, and bring people together through networks and communities of practice as well. And ultimately, we want people in Southall to take a pride in where they live, and to make Southall a better place to work, live, study, and also create a different way of working between groups, community organisations, faith groups, schools, businesses, public health, community and voluntary sector, and beyond. At this point, I'm going to hand over to Rajinder Singh. He is the head of transformation in Let's Go Southall, and is one of the sort of founder members of the social movement. So Rajinder, over to you. Thank you.
Thank you, Chris, and good evening, everybody. Firstly, apologies, I'm actually lying down, and due to a back injury. It's not because I look slightly disrespectful. Lovely to have the opportunity to present here. I think we should start with the point that Sport England's objective and central government's, the DCMS objective, was to look at these pilots up and down the country. And I think if we home in on Southall, we've had health inequality and issues, particular issues in Southall for a long time. Like stubbornly, these are very stubborn issues that have not gone away, and from decades of best effort endeavours from the system, from the council, from the people themselves, we haven't really made a change. So innovation, tackling problems in a new way is a fundamental kind of pillar of our approach of all the pilots. And we have a particular approach in Southall, which is, as Chris mentioned, is being observed very closely. So our light bulb moment, or when we really thought about this and what can we do, how can we make this change and use this sort of once in a generation opportunity from Sport England to make something that's long lasting, has an effect. So as Chris mentioned, we're really about the people, putting the people at the center of dealing with their issues. And I know this wording is said so often, but the social movement is really doing that, is really putting the people at the center. We've got so many local people that are engaged, that are being asked questions and given opportunities that they never had before. And untapping that resource is a fundamental principle of the social movement, of getting the people engaged in a new way and unlocking that momentum and creating those ripple effect. So our accelerator from the 2.5 years of already working in Southall and looking at pathfinding and looking at different approaches, we trialed the social movement. We went to Sport England with quite a comprehensive report to say these are our ideas, and we want to blend. We have a blend of people power via the social movement with leadership development. And I think that's really important to say, that we have a two halves of development, of capacity building of the people and supporting them to basically come forward and take control of their lives and to look at their conditions and tackle their conditions from their own perspectives. And that's a completely different way of solving these problems. So I think it's very timely about how we're looking at the health and wellbeing strategy and the review of the strategy. And also we have this injection of opportunity to make a difference in Southall and potentially replicate that in other areas of the borough. So we got assessed by our peers, by Sport England executives, and they like the blend of the social movement and the people and the direct infrastructure investment, which Councillor Anand just alluded to, in terms of the cycling. The cycling initiative, I'm going to move on to shortly. But basically, we got a thumbs up, we got assessed, we got the thumbs up to go ahead. This diagram is it kind of replicates what we're doing as a honeycomb model. So we have 5 teams which look at all the different social demographic population in Southall. So older people, men, women, families, people with long-term disabilities and conditions. So we have 5 teams. We have organisers who are Southall people. These are the people that probably never normally come forward, and we develop them. We teach them an approach to engage and to create action. We call it a call to action. So we have people in Southall, and we've got a team of 50, 60 people which are from Southall, which are working about a day a week with us. And these are new people, and they funnel into all aspects and all parts of the community. And I think that lattice approach is something new. I think Southall has always been successful in its own different areas and faith groups and different people, but I call it ridge building. So we build these ridges really high and we wave to each other across these mountains, and wonderful scenery, but we never really work together and come together. So social movement is a way in which we change the way that we work together, and we're really using that momentum and power. And even in the pandemic, these figures are pandemic figures. I think we would have accelerated much further. So the accelerator has 4 strands, and I think this diagram explains the accelerator. It's one diagram that kind of fits all and explains all the areas. We have social movement underneath. We have waves of campaigns. We're doing a lot of leadership work with council executives, with councillors, with faith leaders, with other community leaders, the voluntary sector, and to get us to work in a new way with the people power and the social movement together. So we have 4 strands in the accelerator. The first one, active environment, is about active travel, is about cycling, walking. It's about using outdoor spaces in a new way with the state-of-the-art outdoor gyms. And we have other plans, for example, the canal towpaths, and we refer to it as a new people's highway. We want to see that being used by the people. It needs investment. I think together we could help create that investment. And we have a CRT feasibility study that's in progress. So active environment is a big strand. There's 2 other strands around leadership, which is really important. We don't want to create a vacuum and create this investment, but somebody has to lead, the people have to lead, the system has to lead in a place-focused approach. So we have 2 streams around, I won't go into the details of leadership development, really critical. Sometimes I do refer to Southall functions in chaos, and individual and very sort of sporadic, and it needs leadership. And I think that's something to do with the people of Southall and how they function independently. So we're bringing them together and creating this new leadership. And lastly, the last strand, strand 4, is the people strand, is this movement, is the people together who are formed together and come into one as from all faiths, all communities. And we're developing that community so it creates a long-lasting, sustainable group of people that work together for the benefit of their place. So maybe go to the next slide, please, Chris.
Rajinder, I'm just conscious we're coming up to 7:45, and colleagues will need to leave at 8. I don't want to cut you short, and I know you have more to cover, but we also have, and it's my poor chairing that we skipped over the Integrated Care Partnership presentation, but I would like us to have time to cover some of that. So if it's all right, if I can just tell you there, colleagues have access to the report and we can circulate the presentation as well. Rajinder, Chris and Jasbir, if there was an ask for our partners who are on the call with us in terms of getting behind this and driving it forward, what would that be, and how can we work together then to make this a success? Sorry to push you through a lot of material very quickly, but time unfortunately is against us.
Yeah, thank you, Chair. I've skipped forward to the slide that actually has our ask, and I would welcome the opportunity to talk to health-based colleagues on this call at a later opportunity, really. At the moment, the accelerator bid, I would say, is a non-practitioner's bid. So a lot of the money is around sort of environmental improvements, social movement and leadership. We would very much have an ambition that the next accelerator bid will be a health-focused one. So bringing in the many organisations and leaders from the health sector to promote a really positive health-focused bid. And some of the asks in terms of getting to that point are listed there, really. So making Let's Go Southall an integral part of the health improvement delivery in Southall, engaging residents through our programmes, integrating the social movement into residents' engagement, and working with our systems change and leadership programmes to discover new pathways. So there's a lot to cover, a lot to do in terms of our health sector, and we really welcome the ongoing discussion from here on.
Can I just quickly add as well that we have an extensive communications plan which will include targeted campaigns, including lots of ways of sort of campaigning for this program. But we would really welcome the joint up working with our health and mental health campaigns with system providers, leaders and community organizations. So it is important for us to be working together and also trying to help at the very low levels of mental health and disability in the community to be part of this program and to be part of an active lifestyle. Thank you, Chair. Thank you.
Thanks, Jasmine, and thanks, Chris and Rajinder, and apologies again for pressing you on. I think that's an approach that the board can and should endorse, and then we can leave it then to Chris for you to reach out to partners and get that working. Does that sound like a sensible approach?
Yes, Chair.
Yes, Chair. Thank you.
And I think Judith mentions in the chat, and I think Chris, I mentioned to you on a call the other week about, you know, social prescribing and getting that buy-in from the CCG, that we can push that. I don't know if any colleagues want to comment at this point or leave that for conversations offline.
I will just come in here, Chair, if that's okay. I actually, the CCG and health partners were very involved in putting the initial bid together. I think through COVID, they have had to put that on the back burner. I'm so pleased to see that there has been progress. So absolutely really keen to re-engage in the whole programme and see how we can see that there has been.
Brilliant, thank you. Great, so I think we've got endorsement. And so Chris, if we leave you, and then others are commenting in the chat that they would be happy to get on board. So let's pick up that work that Neha says, you know, we had started together and drive it forward. Cam, very briefly.
Thanks, Josh. I just want to say, as a councillor in South of Broadway, that this is all very exciting and I really enjoyed that presentation. And just very quickly, I'm the Cabinet Member for A Fairer Start, so that covers schools and children's services. And I would just have liked to have seen maybe some engagement with schools and some physical activity to be encouraged amongst children, and maybe somewhere we can find some money in all of this to do that. Thank you.
I'm sure Chris can pick that up with you. He's nodding. Fantastic.
Absolutely.
Great, thank you. So let's move back on the agenda. Apologies, I got confused by the two integrated items, but we moved to the integrated care partnership item, and I will hand over to a colleague for their presentation, and I'm not sure who was delivering it. Apologies. Neha.
I think, yeah, Neha's going to take it briefly through, and we've got some public questions too to link to this presentation.
Thank you. Apologies, my internet is a little bit flaky, but I'm hoping you can see my screen. And
can't see anything yet, I'm afraid, Neha.
Ah.
I can tell that it's trying, at least.
I wonder if it, just because of my internet, I wonder if it's better if I just talk through it. We have shared the report, if that's all right.
Yeah, it is on the website.
That's right. So just as context, we have brought reports to the Health and Wellbeing Board in the past around the Integrated Care Partnership and that we were setting this up, but just because of COVID, we've actually really strengthened our partnership work. Just about all the partners that are on the Health and Wellbeing Board today are part of the Integrated. It's just Care Partnership Board. So I'm going to start by quickly talking through the initial slides on the pack, and then one of my colleagues on the call will just step in for any of the more detail. But I'm conscious of time, so I won't. So as you can see from the slides, there are a number of partners involved in it, and our Integrated Care Partnership Board meets on a monthly basis, every 2 months at the moment, and the Operational Delivery Group, which is tasked at actioning the outcomes from meets every 2 weeks at the moment. We've got a really strong foundation of integrated care working over the last few years, and we've worked really closely with all of our health colleagues, voluntary sector, public health colleagues to really drive the integrated care agenda. And slide 79 of the big pack, where it says strong foundation for IC. Some really major pieces of work to drive our integrated care agenda. which has come to various committees and from CCG, but also health and wellbeing boards and scrutiny panels as well. I'll just pull out a couple of them. Our strong Better Care Fund and Section 75 with the local authority really strengthened our relationships, and actually it's gone from strength to strength. With the COVID pandemic, we held a board meeting between health and local twice weekly and 3 times weekly, and we've been able to pick up the phone, just respond and act as quickly as possible. Primary care networks where our GPs are working in much more networked way. We have really all around Northwest London, so they go and attend all of the hospitals across Northwest London. So a part of the initiative is to ensure that our acute pathway colleagues and colleagues are at that table as well as we're having these discussions. And the Ealing standard, which is a huge piece of work that we did to a set of standards for all of primary care, and then the community partners, Ealing community partners contract the procurement that we did as well in partnership with the local authority. Just to put through. The next slide in that pack describes how the system, what the national sort of definitions are around how integrated care works and what that means for the local system in Ealing and who's at the table and what sort of what we mean when we're saying PCNs or locality groups or the integrated. The next slide describes
Neha, I think I've lost your sound.
So, Chair, it's Chris Hilton from Ealing Community Partners. Neha had envisaged that there may be some technical difficulties with her connection and asked me to be ready to step in if her internet conked out. I'm happy to do so if you're happy.
Please, I think we've struggled along, Neha, as best we can, but it's cutting out a bit too much. Chris.
So Neha was on slide 81, where she was just describing the delivery structure of the Ealing Integrated Care Partnership. And I guess one of the key things to highlight on here is the role of the Health and Wellbeing Board itself. As a public board which to which Ealing Integrated Care Partnership Board would expect to be providing regular updates and reports, in addition to the other parts of the Northwest London system, including what is currently the single CCG for Northwest London and the emerging integrated care system across Northwest London, and each of the organisations forming the Integrated Care Partnership, our own organisational boards. You can see within the structure that's described, there are certain tons of acronyms in the way that the NHS always likes to do. But to the left, a description of how some of the primary care is overseen at a Northwest London level. And also the interfaces with some of the Northwest London work that's happening across the system, which all of the health partners are and the local authority are part of. I'm going to move down to slide 82 in the interest of time, just thinking about some of our partnership responsibilities. And just noting that even though all of the organisations remain a statutory organisation, we all have responsibilities to hold each other to account. And you can see in this description a number of those different parties, including my own organisation, West London NHS Trust, and the local authority, and the acute trusts, representatives of which Simon on the board today, representing London Northwest. At the centre, the role that we hope to emphasise around patients, residents, citizens of Ealing, and the place that Healthwatch has on the board, holding the system to account and helping us to drive improved outcomes for our community. I wasn't going to go into the details necessarily of all of the individual priority programs because there's a sort of appendix with a lot of information to read, but just to give you the headlines that each of the providers and partners have worked to identify a number of areas that we wished to prioritise, including children and young people, older people in care homes, urgent and emergency care, population health and inequalities, linking to some of the discussions that we've had earlier today, and the work that I'm the SRO for is integrated network teams, which is around the wrapping of community health and care services around the primary care networks to actually start to develop teams that really work together at that kind of neighbourhood level. And obviously there are key enablers for this, including our desire to engage strongly with local residents, including through our existing patient participation groups and a whole series of partnership boards, many of which report into the Health and Wellbeing Board, and also recognising our need to work together around estates, digital innovation and the data, and also workforce development. So I noticed that Judith has put her hand up, but rather than go through all of the individual points on the remaining slides, the key really was to share with you at this early stage the initial thinking that those work streams have developed, and some of the priorities that we'd like to be working on over the coming months, and some of the approaches that have been taken to setting some of those priorities.
Great, thanks, Chris. Judith.
Yeah, I was going to suggest that we bring the priority programs back in detail at the beginning of the next meeting, and we go through them and really get people's engagement in the discussion about what we're trying to achieve. Thank you.
Thanks. Just before Fabio and Vijay come to you, there were a couple of questions from the public I wanted just to make sure we'd covered off before we finish. I think the one around representation on the subsidiary group, I'm not sure that was in the paperwork, although I think, Chris, you did touch on accountability. If we can just confirm who is on the operation delivery group.
I think Neha may still be struggling with her question, so I'll attempt to answer this. So Sarah Rushton is the ICP lead director. She is employed by West London NHS Trust. Also on that group is Judith Finley, Kerry Stevens and Anna Bryden from the local authority, Vijay Taylor and Neha from the local CCG team, myself as the Community Services Director, and Joe Manley representing mental health, both from West London NHS Trust, and Sid Datta from the GP community. So we are all accountable to our own organisations, and if there are any issues between us, these are escalated up to the ICP board, but really this is a working group trying to drive the ICP board agenda forward.
Thanks, Chris. And then there were just a couple of questions on the board, and apologies to those not being able to ask them themselves, and for the interest of getting through them quickly, I'm taking them from the chair, just in terms of why or whether the board will be meeting in public, and then kind of tracking its actions as well publicly.
I could answer that. Do you want me to answer that question?
Okay.
Yeah, Vijay.
Yeah. So as it stands at the moment, in terms of the public engagement, in terms of the structures that we have, so we have at the moment our single CCG across North West London, which is in the public domain. And then locally, we have our Health and Wellbeing Board. At the moment, we are having ongoing discussions and making progress with respect to the ICP once the ICS becomes a statutory organisation, which will then in fact will also be in the public, and then the ICP will follow suit. At the moment, what we're doing in terms of public engagement, we definitely are looking at having public engagement in our priority groups. In terms of what our priorities are in terms of delivery of those. So it will be important that we do have public engagement as in association with the Health Watch and other local organisations and community and charities to help us shape and deliver our priorities for the next 12 to 24 months.
Thanks, Vijay. Fabio, a very brief question or comment.
Yeah, it was, well, I think Judith mentioned this is going to come back, but it was just really on the objectives, that some of them are really specific, which is great, but others are quite broad brush. Like there's one on like improving oral health. I was just wondering, like, in terms of underneath these, is there sort of, you know, what success looks like in the year, you know, over the next 12 months in order to be able to really track, you know, what these objectives are and whether they're, you know, whether they're being achieved? Because some of them seem very broad, and I guess what the focus is on some of these isn't totally clear.
Possibly a broader question than we have time for at 2 minutes past 8. Judith, you've got your hand up. Was that to respond?
Just very briefly. Fabi's actually absolutely right. We're in the process of developing our plans, so some of them are more articulated and building on existing work, and others are coming in new. So by the time we come back to the next meeting, we'll have a stronger plan to present and with clearer timescales and outcomes. Thank you.
Sarah.
Yeah, are you really not going to let me speak?
Sorry.
I'm here on behalf of our campaign. Are you really not going to let me ask my questions?
Eve, I haven't said you can't ask a question. I'm trying to get through the agenda as best I can, and shouting out and interrupting it probably isn't the best way to do that, please. I was just calling on Sarah to respond on that, and then we will move on to, because I don't think your questions had been on this item. So Sarah.
Thanks. Just to say, I do think it is really important that we set some outcomes, both shorter term, what we want to achieve, but also longer term outcomes. So what do we hope to achieve in these priority programs? And actually, they need to be outcomes rather than sort of outputs. You know, if we're trying to get better diabetes control or whatever, we need to state that and by how much. That is a bit of a work in progress, but we will be bringing that back over the next few months in each of the priority programs.
Thanks, Sarah. And Eve, apologies. There was one question on the other side of my sheet of paper that I had missed. So my apologies. Yes. I think the first one, in terms of the terms of reference, I think have been added onto the CMS page. So those are available for the as requested. I think Chris had mentioned about the engagement and how that might work. I think then we can probably ask then on the suspended services, so trauma orthopedic service, overnight emergency service.
Sorry, Chair, I don't actually think that Chris has answered my question, because that wasn't what my question was. I'd be really grateful if you could just let me ask my question, which was actually about the Health and Wellbeing Board in relation to the ICP. It wasn't specifically about that, and it will be quicker just for me to ask it. And
Go ahead, Eve.
Okay, so what my question actually was, and I actually think in a way this meeting has answered it, is at the last Health and Wellbeing Board, I was told that the way in which we could engage with the ICP was at this actual meeting. And my question was, how do you envisage that we can actually do that? It's talked about providing constructive feedback and challenge if the main arena of public accountability is seen as this Health and Wellbeing Board. And given the lack of time that there is for us to do that, I really would like to know why you think that the Health and Wellbeing Board is the correct place, and why it isn't, for example, a separate structure, you know, the ICP board meetings, which could be open for the public to observe and ask questions, which seems to me more appropriate. So that is actually my question.
Chris or Neha, did you want to pick that up very briefly?
So I guess I'm happy to give an initial response. Others may wish to add. I think this is something that I think we're all very keen to do, to make sure that there is local and patient engagement in the work of the ICP. The ICP isn't a statutory body, but is about the partners working together, and it was certainly the view of the board in our recent discussions that we would want to provide very regular updates to the Health and Wellbeing Board, and also to continue to find avenues for patient engagement and involvement as part of the work that we're all doing, including trying to find ways of engaging people with lived experience to support the service changes and co-production of some of the changes that we're doing. I guess that approach would also include voluntary sector representation on the board and at all of the different subgroups and patient involvement in the subgroups. So it's certainly something that we've been discussing, and it's part of the commitment of the board to make sure that we've got those perspectives in the work going forwards.
Judith, do you want to add to that?
Chris has said what I was about to say, but just to add to it, we'll work on the agenda planning so that we give time, better time in this agenda for the ICP work and that proper engagement with our residents. So I think the structure of the board hasn't quite worked in terms of the timing for everything today. Thank you.
Yeah, and I think, you know, just from the political side, it does show we've just, you know, the complicated reforms and additional structures and layers that get put in do pose a challenge for us holding partners to account. Peter,
Yeah, I mean, Chair, that was going to be precisely my point, which is like, there is a huge question about the democratic accountability of the NHS and how it's governed in the context of decisions that it takes, and the powers that it has, and the priorities that are made at a national level and therefore are cascaded out locally. We have a Health and Wellbeing Board under the Health and Social Care Act that has a specific set of responsibilities and powers to shape that agenda in partnership with our NHS colleagues. You know, this is a forum in which we can have those discussions. This isn't a forum in which we can direct. Now, I have my own views on this and have expressed them over the many years about the democratic accountability of the NHS. But we've got to find mechanisms of having those conversations. And you know, these are not going to be unfamiliar themes to anybody who has ever spent any time whatsoever working in leadership roles within the NHS. But our ability to sort of do that in this environment is limited.
Yeah, and I just, you know, adding, you know, as Peter says about, you know, the way in which it is structured, putting local authorities into the integrated care partnership as well gives us as elected politicians, and from mine and Peter's side, difficulty in terms of working as equal partners, but also stepping outside and holding to account as well. So we will find a way to make this meeting work in that respect. Even as Judith says, we had some rather large reports on, and we'll look at switching things around in future. Simon, I noticed you've got your video on. There was a quick question from Eve on some services at Ealing, whether you've got time just very briefly to cover that now, which is the trauma orthopedic service and the overnight emergency surgery.
Yeah, I could do. So the review process has commenced and is chaired by the Trust Deputy Medical Director, Dr. John Baker. It's got independent external input from an orthopaedic consultant from North Middlesex Hospital, along with strong representation from clinicians at Ealing Hospital and across the Trust, as well as senior operational staff. The review panel has met twice so far and is scheduled for a further couple of meetings over the next couple of weeks before planning on making a recommendation to the Trust Executive Group in July that we will then share before confirming the outcome from there.
Great, thanks, Simon. If we can get an update on that, and I'd suggest also take it to the Health and Adult Social Services scrutiny panel, who might be interested in that as well.
Yeah.
Ask when the public might get to see any of this, Simon.
So at the end of July.
End of July.
Yeah.
Thank you.
Thank you, and apologies, we are at 8:10, and we've rattled through some very big items.
I do have another question. It's on the
I know, Eve. So what I was going to suggest is that if NHS partners wish to drop off, that I think the rest of the questions are for Ealing officers. I think the only one was from Eve in terms of the NHS digital GP data share. Just to confirm, Eve, as a council, we have been pushing that and making people aware of the deadline. The deadline has extended, and we will continue to make residents aware of that as that new deadline in September approaches. I don't know if Neha, your sound is working from the Northwest London point of view in terms of making people aware and letting them know they can opt out of data sharing.
I can.
Yeah, VJ.
Yeah. So obviously, when NHS England, NHS X, NHS Digital announced this, In fact, they announced it I think within about 48 hours in terms of this, the principle around the data sharing. And then clearly there was a lot of unhappiness, and hence that the timeline and decision was put back until September. Clearly, it's important from a health perspective, particularly for GP practice and their population, that they understand have a full understanding around the implications around opting out in terms of the data sharing. North West London CCG are working through the support to facilitate GP practices to enable them to empower their patients to make those informed decisions regarding opting out. Once a patient does decide to opt out, the mechanism for this is specific read code in the GP IT system, so that extraction won't take place from September. But we will be having engagement with our practices individually in our practices. We will be updating the websites of each practice, and that will also be done centrally to give our patients the information that they require for them to make that informed decision regarding opting out or staying opting in. So it happened in a way where it sort of happened within a 48-hour window when it was announced, and we were all it came as a surprise to everyone, but common sense prevailed, and that decision has been then put forward until September. So we will now be working with our local population and our local communities to ensure that they are well informed about that decision.
Can I just say, Chair, that obviously that's good that there is more information going out, and I wonder if the council could consider putting it in the newsletter that goes out to residents. I don't think I've seen it yet, so I think that would be really good if that could be done.
It should already have done so. It's certainly been on the council's social media, and if it has, we'll double check what went in Ealing News Extra, and if it didn't, we'll make sure it goes in again, and it will in future in the run up to the deadline as well.
Thanks, Chair.
Yeah, I've already authorised that to happen, so I'm sure it will happen if it's not already. I'm pretty certain it did on Friday.
Okay, thank you.
Thanks. And again, apologies, colleagues, for the length of time. We just have one final question from someone who is here. So I'd like to make sure we do cover that. And that was for Judith, I think, or Kerry. Roy, this was your question in terms of the impact on adults with learning disabilities. And Judith, if you wanted to pick that up for Roy.
Okay, yeah.
Or Kerry, sorry.
Yeah, do you want me to ask the question? Okay. I want to draw the chair's attention and the councillors and the whole board's to the recent report by the Association of Directors of Adult Social Services on the impact of the COVID pandemic on adults with learning disabilities, autism, and their family carers and service providers. And that this report has drawn attention to the devastating effects of the pandemic and the lockdowns on this vulnerable group. And the report is obviously on a national scale, a national basis. But I wanted to ask what was the situation in Ealing, and how does Ealing compare with the national picture? Is it better or worse? And more importantly, how can the services that have been rather devastated be rebuilt? And these services include health issues as well as social care issues. So it's relevant to the health and social care inequalities. And there's issues around annual health checks, hospital admissions, discharges, daycare, supported employment, placements that have been lost or suspended, and support for family carers generally. And really just to draw your attention to this report and perhaps ask it for it to be on the work programme in the future. Thanks.
Thank you, Roy. Thank you, Chair. The council's been working closely with providers throughout the pandemic to ensure to minimise the impact on people who use our services and their carers. Services are reopening in line with the national government roadmap for services to reopen. That said, we're extremely conscious of the significant impact that the pandemic has had on certain communities within the borough. We're working with Health Watch to develop a survey, which we hope to have a completed report for around November. We've already proposed to take that to the Health and Scrutiny panel, but if the chair would be interested in us bringing back the update to this group as well, it'll include surveys of people who use services, their carers, as well as conversations with the range of partnership boards that we have with people who use the services across adult social care.
Yeah, I think let's bring that back here as well for an update so we can keep an eye on it. Sorry, you have your hand up. I'm not sure from the name on screen.
My name is Joanna Paul. I'm Director of Operations, working with Simon Crawford at London North West.
Perfect. Thank you. Sorry.
No, it's fine. I was a little late, I'm afraid, joining the traffic. But I just we did in terms of this question, wanted to maybe just give a little bit of assurance around access to services for patients with learning disabilities, etc., from the Trust. It's actually Learning Disabilities Week, and we've got a range of events on this week, which we've circulated within the Trust and accessible to all of our teams. In terms of admissions and discharges specifically that was cited, we have a protocol for patients who are admitted with learning disabilities, and we use an admission toolkit. We have a children and young persons health passport and adult passports that we use, health passports. And the toolkit encourages patients to access a circle of support meeting with within 5 days and a risk assessment. And we aim to have no more than 6 patients needing admission at any one time in terms of offering other options in terms of support, which we've been able to deliver. And we use Coordinate My Care since 2019 for patients who've consented to hold on their action plans, and also to enable them to make choices for treatment in advance of further care needs. And that's been very effectively utilised and evaluated, and was useful very much so within the pandemic. So that's services that then can be accessed, and plans can be accessed, the health passport, through a variety of GPs, 111, etc., when they're put onto that. We have a process of flagging for patients who are admitted. We've got learning needs, and so that we can make sure everyone is aware of that and that the plans are attached to their care. And during pandemic, we absolutely were utilising video consultation with to allow our patients contact with their families and carers. We have had some good practice recognised within nationally within the Changing Lives work and books that have been produced in partnership with the NHS. And I think just around annual health checks, which were mentioned, in Ealing, we have 89% of our learning disabled patients are registered with a GP. And whilst the target nationally is for 67%, we've achieved 91% of those being reviewed, with 89% with completed action plans. Lastly, 75% of our patients registered with a GP have also been vaccinated of the COVID. So just to give you a quick overview of some of the things that we've been doing.
Thanks, Joanna. That's very helpful.
You're welcome.
Kerry, is that a legacy or something to add?
Legacy, sorry, Chair.
Fantastic. Well, given it is 8:20, I know we have the work programme item to discuss, although we don't have a work programme given events of the last almost 18 months now, but we can come back to that, because I think it is now 8:20, and I know colleagues are expecting a 2-hour meeting, so apologies for a rather ambitious agenda this evening. We will review that as we move forward and shape that work programme to make it more productive conversation rather than so rushed. We'll meet again on the 22nd of September. From my perspective, doing so virtually probably helps attendance. So if people are happy, given this is not a formal decision-making meeting, for us to continue doing virtual meetings, internet connections notwithstanding, probably does help people attend better than trying to slot into diaries in person. Thumbs up from Councillor Conti at least. So we'll work on that basis and hopefully see you then virtually on the 22nd of September. Thank you all very much for a longer meeting than expected and the excellent reports and recommendations.